Welcome, everyone, to the Decoder booth at ADLM for this podcast titled The Infection Decoder, How MeMed BV is Changing Emergency Department Care. I am your host, David Engman, a pathologist and former chairman of pathology at Cedars-Sinai Medical Center. Today we are joined by Suzanne Jarvis from Columbia Memorial Health in Hudson, New York, an early adopter of the MeMed BV test in the emergency department. Suzanne, please tell us about yourself, Columbia Memorial Health, and your position at Columbia.
Thank you, Dr. Engman. I'm Suzanne Jarvis, and I am the chemistry serology supervisor at Columbia Memorial Health in Hudson, New York. We are a small community hospital with about 38 primary care specialty centers and are part of the Albany Med Health System. We are located approximately 35 miles south of Albany and 150 miles north of New York City. Our population primarily is 2 counties, which is over 100,000 people that we serve, and we have a very busy emergency department.
So can you tell us more about that department, like the patient volumes and most common complaints people present with?
So our emergency department sees around 23,000 patients a year, and our aging population leads to mostly sepsis-type patients that present, COPD, CHF, pneumonia, and nursing home patients that come from area nursing homes as well.
So if we were to estimate among all the ED patients, about how many or what fraction present with possible acute infections?
I would have to say probably 75 to 80%.
Wow, okay.
Based on our population.
So I'm going to describe the MeMed BV test, the subject of the podcast, in a little bit, but how were patients presenting with possible infections evaluated, worked up before you considered implementing this MeMed BV test?
So the traditional testing process or testing panel would be performed, including CBC, lactic acid, blood cultures ×2. That would be it as far as laboratory testing. It would be up to the physician at that point to make a decision on how the patient presented and whether they prescribed antibiotics or did not, or wait for culture results to come back.
So at that time, when those test and imaging results came back that did not provide a clear picture of the source or type of infection, how did the ED physicians handle those patients? How did they manage those patients, whether they were admitted or discharged?
Depending on the individual patient situation, most of the time they were probably admitted and monitored and awaiting those blood culture results, or prescribed antibiotic and discharged when perhaps they didn't need that antibiotic.
So what challenges then did you hope to overcome by evaluating this MeMed test initially?
We were looking to have more of a definitive idea of a viral infection versus a bacterial infection, and to know definitively that that viral score was going to give you that confidence of antibiotics not needed and potentially patient not needing to be admitted, as well as no bacterial infection present.
So, as I mentioned, the subject of this podcast is the MeMed BV test, and BV means bacterial viral. So the test is a test for bacterial viral discrimination. And this works not by identifying the pathogen, whether it's a bacterial or viral pathogen, but indirectly by measuring the human immune response to infection. And it does that, because of that measurement, there are just some general and reproducible differences in the host immune response depending on whether there's a viral infection or a bacterial infection. And by exploiting those differences, the test can distinguish bacterial from viral infection. It has a very high negative predictive value for bacterial infection of nearly 100%. a very good, but not quite as good, positive predictive value. So it's basically a test that rules out a bacterial infection. So let's go back to the beginning. How did you first learn about the MeMed BV test?
We discussed we reviewed the assay with the Decoder team and decided that it might be something we could utilize at our facility. So we were able to do a validation and see that the benefits of this test really would be great for our hospital, and bringing it on board with a proper rollout and implementation could truly help our patients, which is ultimately what we're looking to do. The costs of admitting versus not admitting, we want to do whatever's best for patient care. That also includes the not prescribing of antibiotics when it is a viral score, so we're not over prescribing and putting a patient on an antibiotic that they truly don't need.
So as you were doing this evaluation, this initial evaluation, what were the key findings during that evaluation period that ultimately led you to implement the test into clinical practice?
We did this study and reviewed the data and found that most ER patients were being prescribed antibiotics and having blood cultures and all the testing done regardless of the actual need. And we were able to see those viral scores where antibiotics were prescribed when they truly didn't need to be. And that was kind of the key to say we can do better as a facility and as a laboratory to provide more definitive testing and another tool, in a sense, to the sepsis protocol to help diagnose sepsis as well, but also to rule it out and not incur the whole sepsis process for a patient.
So how did you ultimately integrate the MeMed BV test into the ED workflow in the evaluation of a patient with possible infection?
We started with first small group meetings with the emergency department clinicians and had excellent support from the ED manager, Caroline Schott. And we were able to do small group educational sessions where they had a good understanding of what the test was and how it could be utilized. And Dr. Alka Shukla from Decoder, as well as Jim Prendergast from Decoder, on site to answer any questions and provide that support and guidance was really key as well. And we found that once we went live, they were not ordering it as much as we thought they should. So we increased our meetings with them, whether it be just going to the department and having a conversation and providing them with educational postcards to give them more guidance. And the recommendation came from the ED to add it to the sepsis order set. So we thought that was fantastic, especially coming from them. We added it to the sepsis order set, and we were seeing more and more utilization of the test and more doctors being comfortable with seeing the result and interpreting the result. But I think the key is providing them with the education and my interaction with them on a pretty regular basis, because there are many different physicians coming in and covering from other facilities in our affiliate and never heard of the test, didn't know anything about it. So to kind of be visible in the emergency department and review the test on a regular basis is still pretty important for the success of it.
Was there any initial pushback from physicians or nurses on the use of the test?
There was initially some just basic concern, like we've always done it this way type of thing. And, the ER doctor knows how to assess and diagnose sepsis. And we understood that, but by showing them the actual real data from our validation and what benefit it could bring to add and provide that additional piece to the puzzle, I think was what helped kind of smooth it along, that we weren't getting any pushback as far as implementing. I also have the ability to, provide this data and discuss it with the directors, the emergency department, pathology, pharmacy, and show them what the real potential utilization will do for us as an institution. And I think that piece was pretty important for them to come on board with.
So, how many different ways can a physician order the MeMed BV test, either as a standalone test or part of another kind of bundle?
So it is a standalone test, and it is part of the sepsis bundle. If it's not ordered in the sepsis bundle, they certainly can order it on any patient that meets the criteria, or on a patient they feel, and I give them that go ahead to order it on a patient you feel that might benefit from it. We're working with the triage nurses. Some of them are actually ordering that MeMed test first, and that is allowing, before they're even in and processing and a doctor gets a chance to see them, we're getting that MeMed result back, and then that's kind of guiding them to where they're going to go with the next step. What tests should be ordered? What is the next imaging study to be done, or what else should be done for this patient? Not always done that way, but it is truly ideal if it is.
So, if you look at all the MeMed tests ordered from an ED, approximately what fraction are ordered as part of the bundle, sepsis bundle, and what fraction as a standalone test, maybe in addition to some other tests?
So the standalone would probably be about 20% of the testing that's done. It's primarily the sepsis bundle that it's being ordered in.
So now that you look at the results, not just during that evaluation period, but after implementation, did you find, or do you find that having the MeMed BV result affects antibiotic prescription practices by those ED physicians?
I do. I do see that they, at times, are still prescribing upon presenting to the ER. However, once they get that MeMed score back, if it is in the viral range, they will stop at that one dose. If the patient is admitted, the hospitalist will look at that MeMed score and say, we don't need to continue the antibiotics, and they'll taper it off. The hospitalists are slowly getting on board. In the beginning, it was very difficult to get different groups together, but they really have come on board and done a great job, because they're seeing those scores with the patient. That's now their responsibility. So they really have a good understanding of the test.
So let's talk about the hospitalist for a minute, because you could imagine that some patients admitted from the ED who were put on antibiotics at that time might not actually have an infection, and the hospitalist might rely on that test to discontinue antibiotics. Or have you ever found that the hospitalists are ordering new MeMed tests on their inpatients?
I have seen, for the most part, they do discontinue after the first dose, and we discussed this at our lab and transfusion committee meeting with the director of hospitalists, and what is their practice and what do they want to see better for the patient care. Also, when a patient does not have a MeMed test ordered in the ED and they are admitted, the hospitalist is ordering it themselves. There was a situation where we had an equivocal result, and the hospitalist was just a little unsure of that, and the next day he ordered another one, not recommended for serial testing, obviously for MeMed, but in this case, that next day result was a score of 100, a high bacterial. So within that 24-hour period, the score went from 50 to 100 because of that immune response.
Well, as you know, infection is a dynamic process, both from the pathogen side and from the host response side. And we never really talked about the score, but they're basically, the test will give a viral score, a bacterial score, or an equivocal score. And that equivocal score, of course, should not be used to inform antibiotic prescription. But you just illustrated how during the evolution or development of an infection, the score can move up through that equivocal zone up to the bacterial score. What about the effect of having a MeMed BV result on the ordering of additional tests that are frequently used in the evaluation of possible infection? Or did it have any effect there, knowing that, for example, that there would be a viral score that came back? Did that affect any subsequent test ordering?
Sometimes the nursing home population that we see presenting at the ED would have similar symptoms of sepsis, and then the MeMed score comes back as viral, and they then order the COVID flu RSV, and in a lot of cases, it's either COVID or RSV positive that we're seeing.
You know, there's something that's a little more difficult to gauge, but equally important, and that is the role of a test like this in reinforcing a clinical decision that is made with less than 100% confidence. Have you, just from your discussions with ED physicians, have you found this test, if it's concordant with the clinician's judgment, clinical judgment about the source of infection and so on, is that an important factor for these doctors?
I think it is. It's still a work in progress because they're still getting a good handle on what the score truly means and how it impacts the diagnosis of different patients, because it is, equivocal or higher, could be a variety of things, could be multiple situations going on for a patient and co-infections that they just are still trying to work through that diagnosis process. But it just is another piece to that. There is some type of bacterial or inflammatory process happening versus a viral score, which there is not.
Now, what about an example patient where this test had a major impact on management? Can you come up with a
Yeah,
example?
so I would say there was a 25-year-old male patient that came into the ED with various symptoms that could have been situationally sepsis, and they ordered the MeMed test, and that test came back as a viral and a 0 viral score. They then ordered CK and did not continue with blood cultures and all that at that point because it was simply a viral score, but they did order the CK, and the lactic acid that was ordered was actually an, excuse me, an 8.0, which with a MeMed score of 0 and an 8 lactic is kind of contradictory. But they were able to see that that CK came back like greater than 40,000, and the patient had to be admitted for rhabdo and did not have any type of bacterial infection, so was not put on any type of antibiotics, but treated for the true diagnosis that they found.
So if you look at your patient population, are there any specific types of patients where the test is more valuable than in others?
I believe it is in our elderly population, whether it's from a nursing home or recently had a situation of a motor vehicle accident, and patient came in unresponsive, and the ED doc did order the MeMed test, and it was, another tool to say, I'm not sure what's going on with this patient because he can't speak to us and tell us, but he had a medical episode that caused the crash, and they were able to use that in conjunction with the other tests to treat that patient.
So now, a year after implementing this MeMed BV test, what's the biggest impact this has had, would you say?
I would say the antibiotic usage is decreasing. It's not where we want it to be yet, so we still got some work to do, but it is definitely decreasing and or stopping after that first dose. And the fact that that viral score patient can easily be separated out for what's the next step for them. What do we need to do with this patient? Most of the time it is a discharge, whether it is discharged back to a nursing home or just a routine patient coming through. But that, and having the test available 24/7, we average about 48-minute turnaround time. So they're getting it relatively quick, and, that gives the ED that confidence that they know they will have that result back timely.
Thank you, Suzanne, for sharing your insights on the MeMed BV test and how you've implemented at Columbia Memorial. For those listeners at ADLM, be sure to visit the DiaSorin booth to learn more about this and other testing offered by DiaSorin. Thank you.
Thank you.